It is just an honor and absolute pleasure to be moderating this panel about a program, as Rebecca said, that has been so near and dear to my heart for many years, and to look around the room and see so many familiar faces who have been kind of key critical elements of this program's success. I'll kind of just give you a brief recap about the program and where it has been. So the program was launched in 2011 as a $100 million grand challenge. It pooled money from 6 different funders over the course of its span to collectively source innovations that would target and tackle maternal and newborn mortality around the time of birth. And instead of prescribing the solutions that it wanted, it crowdsourced them. And this was kind of a novel system at the time. And it crowdsourced solutions from all over the world. So we were looking at around every corner, under every stone, to get what we thought were going to be the boldest and brightest innovations that would tackle this problem. And specifically, we looked for ideas around novel ways in science and technology, service delivery models, and ways to create demand for better healthcare. In addition to grant funding, we also sought to create a community of innovators. We recognized that not one single person, not one single entity could solve this grand challenge. And so we set aside funding each year to bring the community together and provide them with space to network, to share ideas, challenges, and also some business model support. And so over 8 rounds between 2011 and 2018, the program funded about 120 innovations from over 90 different organizations around the world. These organizations spanned for-profits, not-for-profits, academia, and about 20% of the innovations received follow-on funding to kind of further support their development to scale. And so today, I'm incredibly excited that 4 of these innovators are here today, and there's many more in the crowd, but 4 will be joining me on this panel to share more about their journey and their progress to date. So first, and I'll call up when I say your name if you'll come up to the stage and you can have a seat. First, we're going to begin with Rasool, who is an experimental nuclear and particle physicist who has made significant contributions to industry collaboration, community engagement, and global health. And it's this piece on global health that he'll be talking about today. In 2010, he began focusing on the provision of oxygen, and he co-founded the FreeO2 Foundation, which designs, constructs, and deploys affordable medical oxygen system for low and middle income settings. Today, he'll share more about the FreeO2 systems, which are now being used throughout East Africa and the Pacific Islands. Following Roger will be Ratul Narain. He is the founder of Bempu, an Indian-based company that aims to raise the standard of healthcare for the millions of infants born every year in India and all around the world through appropriate and affordable health technologies. He has a history of innovation and engineering, having developed several medical devices for Johnson & Johnson and Embrace Innovations before founding Bempu. He will speak about 2 of Bempu's Saving Lives at Birth funded innovations, the ApneBoot, which was a device to catch and treat newborn apnea, and the TempWatch, which is a temperature monitoring device for babies. Notably, the TempWatch was named one of Time Magazine's best innovations in 2017. And then next we will have Brent Moellenberg, who's the Director of Engineering at We Care Solar, a nonprofit organization which designs, manufactures, and distributes the Solar Suitcase, which is a small solar power and lighting system specifically designed for use in maternal health centers around the world. Brent joined We Care Solar in 2010 and has since that time been in charge of designing, sourcing, and manufacturing the Solar Suitcases, which are currently being used in over 9,000 healthcare centers worldwide. Finally, we have Rebecca Richards-Cordham, who really probably needs no introduction to this crowd. She's focused her career on the development of low-cost, high-performance technologies for remote and low-resource settings. Her research and engineering design efforts have led to the development of 40 patents, the publication of books, chapters, research papers, and she's been honored with many prestigious awards and recognition for her tireless work, including the coveted MacArthur Foundation Genius Grant, and being named one of the world's 50 greatest leaders from the Fortune magazine in 2017. She's here today to share more about the Pumani Bubble CPAP and its reach around the world. So after the four panelists have presented, we'll be opening it up for Q&A, so please keep your questions ready. And then, just as a note, all of the questions will be done from the 2 mics in the back of the room. So I encourage you guys to think about your questions now. And with that, I'm going to invite our first panelist, Roger, either to the podium or from his seat.
Oh, sorry. Good morning, everyone. I've been told I have to be behind the microphone so that you can all hear, and I can gather you can all hear. Is that clear? So I don't have to be behind this mic. Okay, so, and I've been told, now I've numbered my slides today, and I have 5 minutes, so there's only 179 slides. When you were pitching at Slab to Karen and Wendy, it was important you had a punchline to really get the audience attention. Do you know what the greatest killer, not of under fives, but of audiences is? It's actually a disease that comes from pressing this and nothing happening, but it's called PPP, and it's called PowerPoint poisoning. And 10 years is actually 5 million minutes, and I have 5 minutes, so it's about 1 million minutes per minute. Okay, so I hope you do survive and don't suffer. Now, it's a physics talk. You don't need to put your hand up if you love or hate physics, because I know you do, okay? And you're quite safe because it'll just be a talk on cathedrals. So this is a cathedral. This is a tour of the world. That's a cathedral called the Australian Synchrotron, or CERN at Geneva, 27-kilometre rings, $8 billion projects. This is the Atlas detector. This is myself and Mark, very proud about the 4 connectors that we made on this Atlas detector. And this was 2012, where we found the Higgs boson, and all physics could rest. And we were excited. And so what you can tell, this is the type of background I come from, global health, no, physics. And so clearly, it's done and done. And we clearly had a lot of fun. And so there was nothing else to do, except we turned the clock back to around about the same time, and I found out about the problems in global health. And we thought, well, as physicists, could we help? So I went on a journey, and I went to Uganda, I went to Tanzania, and I realized that those cathedrals that I lived in were very different to where other people lived in. And that's my wife Anne and I in Kibera. And we decided to actually join the Slab team and pitch. And we pitched some nutcase ideas, I know that, and they were weird. But let me tell you about the 4 I's. You see, innovation is wrongly spelt. It has 4 I's. The first I is that you have to have ideas. And so as physicists and engineers and scientists and biomedical research people, we've got lots of ideas. So that's a tick for the first I. But the next thing you have to do is actually get out of this lab. And so we actually had to implement. Now, that was a big shock for us because I'm from a university where we get paid to go in this circular reference of producing papers and just keep on building things in the lab. But we got out and we had pitched this idea that we could make oxygen using no electricity. And I remember our original pitch was going to be 6 months. It took us 6 years. So we weren't good at judging that. But then we got it out of our lab and we got it across into country where we had to learn about building teams. So it was a big journey for us, well outside of our comfort zone. And we put this oxygen system out in the middle of nowhere in Uganda and tested it and validated it, and we're very fortunate for Slab support. So that's the second I. But that's still not good enough because there is a third I where you have to implement. But I think what Slab did for us, it actually empowered us to be bold and brave and go and raise more money and build teams because we realized that we as scientists weren't going to do it. And then we did another thing called spinning out. And spinning out a not-for-profit, fantastic, tell the audience, 17 minutes to go, I've just got there. sorry, I can't read. Yeah, anyway. So we got out and implemented. And the one thing I learnt to do was pivot, because we realised what it originally proposed was never going to work on a scale. And Noah, I can't remember, oh, he's sitting over there. I don't know how many meetings we had with you where I learned, oh my gosh, Roger, you're going to need to pivot. And so we built teams, and that was the key to our success. But then the pivot was, we actually realised that it wasn't about the technology. It was about the service. And it involved the training and involved the maintenance, and that's where we embarked on knowledge transfer and building teams in country. And it was about data. We used all of our skills as scientists to actually capture real-time data and make these things work and made them rugged. And I remember flying to, this is a SLAB event in 2018 or 17, and we finally treated our first child. And baby Francis was there, and we had therefore moved to our last eye, which was Impact. Now, Peter Singer kept asking me, how many children have you treated? And the answer was 0 for many years. 0 was that lovely number. So I won't take you through the journey. I'll take you through simply the fact that we actually moved from our first country, which was Uganda, we moved to Tanzania, we moved into the Solomon Islands by building more and more teams. I'm clicking and it's almost there. And we finally reached 2024, where we have now treated 16,000 plus kids. And that was all thanks to SLAB, pointing us in the right direction. And so the statistics there don't really pick up the impact, because the networking was the phenomenal bit. And that's really what empowered us as our major change. Yep. And so I come up to my last slide here, which shows pictures, which I can't speak about, but the pictures tell the story, which was the empowerment of teams. And so at the University of Melbourne, Francis is still on the side of the wall. I took that just before leaving to come here today. And so my closing thoughts are, it's not about just knowledge. Imagination is actually much more important than knowledge, but the key to imagination is to actually empower people through education. And that's what I'm spending most of our life, most of my time now doing, which is sharing the knowledge we have and stimulating curiosity. So thanks very much, and I'll pass back to Karen.
Thank you, Roger. All right, I'm going to pass it now to Ratul.
So hi, I'm Ratul. I'm the founder of Bempu Health. It's really an honor to be back with everyone here and have the opportunity to present our work with you here today. So we're a Bangalore-based organization that develops innovative devices for newborns. And I thought in 5 minutes, I'll just give you an overview of what we do and kind of what happens since lab. So I'm an engineer. I used to work for Johnson & Johnson, but I always wanted to get into global health. And about 13 years ago, I moved to India. And I spent about 2 years in the field in different hospitals and clinics trying to understand firsthand why so many babies were facing injury or dying in India. And while I was doing this field research and talking to doctors, I was also doing secondary research. And we know that the vast number of reasons why newborns are dying or facing injury are preventable. So my team and I focused in on one area. Do you see a laser? Oh, yeah. Prevention and management of hypothermia, which the literature showed could prevent almost up to 42% of neonatal deaths. And so what we developed as a solution for this is what we call the Temp Watch. It's a tiny bracelet that's given to babies usually just before they're being discharged to go home, and it monitors their temperature continuously day and night. And if the baby is warm, the Temp Watch keeps blinking a soft blue light. And if the baby is ever cold or hypothermic, it blinks a red light, it beeps, it wakes up the mother or the father so they can warm the baby well before any hypoglycemia, hypoxia, any injury occurs. And when the baby's warm again, it starts blinking a soft blue light again. Now that we've deployed thousands of these, we also know that in certain cases, it will keep blinking a red light for 2 hours. And if this happens, that means that the baby is unable to be rewarmed and likely has an underlying issue like sepsis, and that baby needs to go back to the hospital immediately to get treatment. So we deployed this, got it out in the market, sold a couple thousand, but really we had a lot of challenges at the time. But that's when SLAB came in, and we were very fortunate to get this catalytic funding that really helped us start to develop some evidence and experience about this, and also make iterations to the product to make it a better product market fit. And over with the SLAB seed grant and later validation grant, we were able to get 13 publications done that showed that the device is accurate, that it's acceptable with parents. And then we started seeing things around behavior change, especially with kangaroo care. So what would happen is that we integrated very well with a lot of the low birth weight and kangaroo care programs. They would give the watch, and if parents didn't do kangaroo care, almost definitely their low-weight baby would get hypothermic and the watch would beep. And suddenly they'd realize that, okay, if I do kangaroo care, it's not gonna beep. And so we'd get this reinforcing mechanism that started happening. And we recently had a publication in Nature's Scientific Report that showed that parents were doing almost twice as much kangaroo care over a 4-week period when wearing this watch versus the control group. And of course, if babies are doing more kangaroo care, they're gaining more weight. And of course, if they're being kept warm, they're also gaining more weight. So we have other data now on other clinical endpoints. All of this was really in our goal to see how we could reduce neonatal mortality. And we, at the same time, SLAB gave us the funding to go work with different governments. And the government of Rajasthan did a pilot study where they introduced the bracelet to their NICU government babies and had a control group, which was their control group, versus the babies that had the bracelet. And babies who didn't have the bracelet, 14% of these babies died within the first 4 weeks of being discharged from the hospital. Of course, these are very low-weight babies in tribal, rural areas. And when the government introduced the bracelet, they observed a 6% death rate for the same group of babies. And so in this pilot evaluation, they observed about a 50% reduction in death for newborns. And when we go back in the data, you see that these parents were calling ambulances when they're an issue. Fathers were doing KMC. So there's a lot of behavior change and observations in that. Since then, SLAB also supported us to deploy with open doors to other funders and other partners. And the government of Benin has also observed a similar trend in a decrease of 14.5% neonatal death at the district health level. And we've had several evaluations done by UNICEF and the US CDC. And we also got the opportunity with, again, SLAB opening these doors and getting sales to UNICEF to deploy in different places. So in places like Papua New Guinea, they've been using community healthcare workers who have been going to the cold highlands and deploying these watches to babies who otherwise may not go to the center. In Cameroon, they've been using it in the NICU. In Benin, even during COVID, they had midwives who were deploying it to the babies. So we've been fortunate that these doors were open for us, and now we've also supplied to several UNICEF countries. I think 12 UNICEF countries, WHO, and other public health groups that have, again, helped us understand that this is a robust intervention. Of course, it's hard to run a for-profit business on just one product, selling to governments and public health organizations. So we're fortunate then that we were able to launch a number of other innovations, including the Kanga Sling, which is a very comfortable tool to do kangaroo care, the Apnea Boot, which we won a validation grant for, which detects when babies have stopped breathing and then stimulates their foot to automatically restart breathing, and the belly button, which is a simple monitor that alerts if a baby also stops breathing. That's it. Was I under 5 minutes? Oh, 5 minutes.
Oops, sorry. Good morning, everybody. I was unaware that we were going to have speakers like this here, and so I'm the dinosaur that brought some paper to read from. But I first of all, I'd really like to thank Karen for the introduction and Rice University for having us here today, and it's really cool to be on the stage with such great leaders in this field. So I'm Brent Moellenberg. I'm the Director of Engineering for WeCare Solar. Now, it's no surprise that the developing world has problems with energy infrastructure and that healthcare around the world is lacking proper energy. And so it's this reason that we started our organization in 2009 to start to deal with some of these deficiencies in energy for healthcare. For the past 15 years, we've worked to develop part of our solution, which is a small, off-grid solar power system, which we call the solar suitcase. So the idea is simple. There we go. Okay. The idea is simple. We basically take a small power system, put it inside a waterproof case, and then fill it with all the necessary bits and pieces, the lights, the healthcare appliances, everything necessary to get into a clinic and quickly install a system. So the idea is not so much that our case remains portable, although some do, but it's basically, it's got to survive the trip out to the clinic, and that all the pieces actually have to get out to the clinic. And anyone who's ever worked in a remote project like this knows, if you get out there and you're short some screws, it's a really big problem. So the year was 2012. We had manufactured and shipped out a total of about 70 suitcases at that point, and we discovered an opportunity to partner with AMREF and White Ribbon Alliance in Uganda to do a project which we submitted to application to Saving Lives at Birth, the second round. Our project submission was ambitious. We wanted to manufacture and install more than 150 solar suitcases in over 100 health clinics in southern Uganda. In one project, we would more than triple what we had already done up to that date. So now, in this project, our systems would not only power the light and small electronics that we were used to, but we would also power small laptops and cellular modems, which we would use to tie these remote clinics to Uganda's health management information systems. So 2013, we had identified the clinics where we wanted to do the installations, and we started shipping systems and doing installation. The project continued until 2015 when we did monitoring and evaluation. And there's a very optimistic person who didn't know what was ahead on the roof there. All right, everybody likes to hear about the problems, and I know that everyone on this stage has had plenty as well, and we definitely did in this project. So first of all, one of the biggest problems was that part of Uganda where we were installing is the southern mountainous region down around Kabale, which is also really close to where Gorillas in the Mist was filmed. And if you can see, that's not an awesome place to try and generate solar power. And so to get around this, we had to install multiple solar panels on each system, which meant we had to put larger batteries on each system. And so it just made everything more complicated and more expensive. Then we were powering laptops, and I don't know if anybody's ever tried to support their parents' computer from a distance, but if so, you know the heartache that that involves. Well, imagine doing that across borders, across time zones, across language barriers, and you'll know the kind of heartache that trying to do a remote connectivity system in remote Uganda could give you. And finally, a lot of the places where we were installing had been so neglected for so long that even once you provide electricity and light, the buildings were in such bad shape, and the staff was often basically non-existent. And so you can only do so much with light. Now, once light was installed, what we did see is a lot of times those buildings would get fixed up and staffing would return. But there was some successes. When we got to the end line monitoring, we could see some of the successes. And among those, we could see that there was an 80% increase in the nighttime deliveries, a 73% decrease in perinatal deaths, a 53% drop in maternal deaths. There was an increased, many reports of increased health worker satisfaction, but I think more importantly, health worker retention, which is so important in those remote health areas. And finally, even with the limited light from the regions where we were working, we could see from our data that we were able to provide 24-hour light around the clock. Project results. So it's really easy 12 years out to forget what it was like back then when we were starting this project. So first and foremost, this was a project that allowed us to show that a simple system like ours could make a difference, that we didn't necessarily have to have one of these large mini-grid systems to make a difference in health outcomes. It gave us quantitative data where we could not only just say, well, we know it does, but this should be no surprise. Light actually does help health outcomes. It gave us a proven track record that we could go on to other funders with and show that, yes, we could actually deliver on what we were going to try to do. And to be honest, it gave us confidence in our organization that we could improve the lives of healthcare workers and of people going to the clinics, and that the work we were doing was important. It gave us the confidence to go on to bigger projects like our Light Every Birth initiatives, which we started in 2017, in which we partner with ministries of health and ministries of education from countries and blanket a country for all eligible maternal health centers to provide light. What this means is we've got an economy of scale, not just of the systems and of the engineering side, but also of the workers and the skills. So it allows us to have staff in these countries. It allows us to have trained installers that gives us a scalable solution. These installers then can go on to become the maintenance personnel that will staff our maintenance centers, where we can maintain suitcases after we install them. And it's that system which has allowed us to install and maintain 9,000 systems around the world. And all of this because Saving Lives at Birth was willing to take a chance on a young organization 12 years ago and accept an ambitious proposal. Thank you.
My pleasure to get to share the story of one of the projects that we had supported through the Saving Lives at Birth program. And it's a story that involves so many people, and it's really wonderful that many of them are here in this room today. And I come from Rice360. It's our Institute for Global Health Technologies here at Rice. And we do two things in Rice360. We teach students. We really try to teach them how to become innovators that can have impact. And we also try to nurture innovations through the idea stage all the way to impact. And the project that I want to talk about, Pumani, actually started as a student project. We have a senior capstone design course in our engineering majors, like most universities. Our course was taught by Maria Oden, and I'm standing in for her today. And Maria was searching for good design projects that had real global health needs. And we were interacting with a number of colleagues at Queen Elizabeth Central Hospital in Malawi, including Prof. Molyneux and Dr. Kandwani Kawaza, who are both here today. And they shared with us the challenge of preterm birth and respiratory distress syndrome and the impact that CPAP, or continuous positive airway pressure, could have. And this is one of the home-built CPAP systems on the left that you can see at Queen Elizabeth Central Hospital. And Maria took that advice and those ideas, came back to Rice, turned it into a project in her senior design class back in the fall of 2009. And you can see on the right the team of students that worked on that project. Here they are, just before they're about to graduate in the spring of 2010. And you can see holding what looks very much like a student prototype is a student named Jocelyn Brown, who graduated in the spring of 2010. And we wanted to really continue with this project to try and take a student prototype and turn it into something that could actually be used to improve patient care. So Maria and I scraped together some discretionary resources, and we hired Jocelyn to work as a post-baccalaureate fellow for a year. She traveled to Malawi. She got a lot of feedback from nurses and physicians who worked in the neonatal unit there. And we wrote a little grant to the Lemelson Foundation. And we got $12,000 from the Lemelson Foundation to help us take that student prototype and turn it into something that could potentially be used as part of a clinical study. And this is about the time that the Saving Lives at Birth had their first call for proposals. And we wrote a grant to the first call for proposals. We wrote a seed grant. And as part of that competition, you had to take your innovation and you had to stand on stage and you had to hold your innovation and you had to say, my innovation is a game changer because... And so Jocelyn and I were going to be the representatives who traveled to Saving Lives at Birth. And we knew that we could not take the little plastic shoebox thing that looked like a student prototype and say, my plastic shoebox is a game changer. So Jocelyn worked very, very hard with an industrial design firm called Third Stone Design to use that $12,000 from the Lemelson Foundation, take the plastic shoebox and turn it into something that is a little bit more professional, a little still in a project box, but a little bit less of a student project. And we were just thrilled when we got the the seed grant from Saving Lives at Birth. What it allowed us to do was to work with Prof and to work with Kandwani to carry out a clinical evaluation at Queen Elizabeth Central Hospital where we compared the survival to discharge for preterm babies who were treated either with nasal oxygen at the time, the standard of care, or with CPAP. And we were able to show that just like in the United States, when CPAP was introduced, survival rates improved from 25 to 70%. We found in our study for preterm babies, survival improved from 25 to 65%. And with that, we went back to the next Saving Lives at Birth competition, and we applied for a Transition to Scale grant. We were sitting in the audience. They announced the winners at the end. It was so stressful. And this one was in Seattle, and they had handed out glasses of champagne for some reason right before. And Jocelyn and I, we had decided that if we didn't get the grant, I had to tell the CPAP nurses that we didn't get the grant, which meant they no longer had a job. If we did get the grant, Jocelyn got to tell the CPAP nurses. And we got the grant, and Jocelyn was so excited, she dropped her glass of champagne and it shattered. But we got the grant, and it allowed us then to do a countrywide rollout of CPAP to all the government, central, and district hospitals to develop training materials, to work with the Ministry of Health, to develop mentorship programs and biomedical technician training programs. Also, it allowed us to work with Third Stone Design to take the Pumani CPAP through the European regulatory approval system. It's now sold by Hadley Health Technologies and available, it's now over 36 countries, available and part of the Million Lives Collective. What we realized, though, through that work was that it really wasn't enough to deliver a single technology. We heard yesterday about there really is no silver bullet. We really need to work to strengthen health systems. And in response, we brought together a huge team of people from now 22 different organizations that became the NEST project, Newborn Essential Solutions and Technologies, which is delivering a bundle of technologies together with clinical capacity building for biomedical technicians, quality improvement efforts, very strong focus on tracking coverage and outcomes data in what started in phase 1 as 4 countries, 67 facilities that admit nearly 100,000 babies every year. Now in phase 2, maybe into 5 countries, doubling the number of facilities and the number of babies that are impacted. So I'll just wrap up with what did we learn by going through that process. I think innovation really starts with listening. If you want to have impact, you need to understand what are the needs of people who are delivering care, and you need to meet their needs and really listen. But we also saw that engaging students, whether it's students at Rice University, at MUBAS, at Dar es Salaam Institute of Technology, at University of Lagos, engaging them transforms their future. Jocelyn now works for Massimo. She just came back from maternity leave. Access to a package of technology can transform comprehensive newborn care. You have to get it there, And distribution and maintenance is a huge piece of the challenge. And I think coming back to universities, nursing schools, medical schools, training biomedical technicians, building that capacity is so important, walking hand in hand with universities and with government and local service providers. So I just want to say thank you so much to Saving Lives at Birth, because none of this would have happened without that initial investment. Thanks.
Wow, thank you all. I know that there are some burning questions out there because we just heard from 4, I think, strong leaders and entrepreneurs in the field who, using their own words, maybe ambitious, optimistic, 6 months turned into 6 years. So I know that there's probably some questions out here where you want to unpack a little bit more about their journeys. Anyone? Yes. Yes, please do. And we can take a couple of questions. Don't be shy.
Hi, my name is Josh Bress. I'm here at Global Strategies. You each talked about, in some ways, different hardware devices that were put out into very remote areas to help people at the point of care. Did you ever gather data back from those devices? I was thinking about the temperature aggregated data. Was there any ability to capture data from the use? Thanks.
No, great question.
Thank you. Great question. Brett touched on it a little bit about connectivity. We equipped, being physicists, we captured data like it's going out of fashion. And we captured a lot of data, which also led us to develop power stabilization, power backup systems, temperature, humidity that kills all of the concentrators, whether the concentrators are left off for a period of time. All of these things informed our maintenance. It's rich data. We did try to look at opportunities to sell that data, but nobody was interested. So, yeah.
I guess I'd just quickly say we early on had started using like external data loggers to capture data, and then obviously it's still out there, so it's really hard to get. We had looked at doing remote monitoring many years ago, and on smaller systems like ours, it's pretty easy for that connectivity bit to overshadow the part you're actually trying to do, which is provide light. And so I think that there probably are new options now that weren't available then because of just increased cellular access, et cetera. But all of our systems, we do actually, we added in the ability to collect data. And like Roger said, I mean, you get an engineer and a SD card and you're in trouble because they're just going to log everything. But what it's great is it does allow you to see not only how people are using it, when they're using it, and prove that your systems are working.
So we do monitor our hardware with a remote monitor that tells when it's on. So anything that plugs into mains power. I would say that to date has mostly been used by our biomeds to look at, is there a problem that needs to be corrected? I would say more importantly, though, is the development of a dashboard to look at coverage for all of the interventions that have a technology component, and providing that coverage data back to facilities and to country-level teams has been absolutely critical in driving improvements in care.
Thanks.
If nobody has any questions, we could answer. If you've got like a 14-year-old that has like some kind of a question about what they're going to do tonight.
What was the biggest challenge you encountered when implementing and scaling the devices? Like, I imagine like getting it into one hospital or serving one patient is like the biggest goal, but how did you expand it further?
Yeah, I mean, we were trying to sell it. And I think one of the biggest challenges for us with the watch was that it was kind of a new category of a product. And, so it's not like, so we not only had to convince them that, we had to convince them that a watch is something that, and you got to measure at the wrist. They're like, we measure here. And we're like, you got to monitor at the home. And the doctor's like, we don't worry about the baby when they're at home. We worry about them in the hospital, and then we assume they're. So we had to kind of invent this category, I think, which was took time, and then it took like pilots and took doctors trying it. A lot of doctors would give it to the parents, and then the parents would never come back and tell the doctors that it was useful. So we had to like figure out kind of how to build this category, get the stakeholders interested and engaged, which is where pilots and things came in. And once we kind of got some of that, pilots funded by SLAB came in. Once we got that cycle going, then there was a little more of demand generation and scaling.
I think so we're a nonprofit, and one of the areas that we hit was there came a point where we needed to innovate and to do a new design on our product. And finding funding for that is very difficult sometimes. It's much easier when you say you're going to put so many systems out wherever. It's much less exciting when you're like, hey, we're going to respin a circuit board. And then the other problem is once you get to a certain size, getting your product into a lot of countries kind of presents this whole new challenge that when you're small, you can hand carry a couple systems in and do whatever you want. But once you start to attract the attention of governments, then that really can start to be a challenge in itself, just the logistics and the dealing. And then again, once you get even bigger, then you can start to meet with the ministries of finance or the ministries of whoever, and then they'll work with you. But that in-between phase is really tough, where you've attracted the attention of customs, but you are small enough where you just don't have the resources to deal with it.
We had to realize it wasn't about the technology. So the statistics that I showed, and yes, we focus on 16,000 kids treated, but we trained over 1,500 health workers. We employed 22 technicians and trained them locally. The key was actually getting the service into the facility, and the technology flowed after that. But I do also share the creative means that are required to negotiate the customs barriers in certain African countries. Yeah.
I'll just add one other challenge. I think we represent a interesting cross-section of different types of organizations, but I think all of us have faced the fact that the need for technologies is great. The number of people that are willing to write a check to purchase those technologies is a much smaller number. And it's a business, right? You have a technology, you have to cover your cost in some way, and it's really, really difficult. And figuring out the path to doing that in a way that is sustainable is, I think, super tough. I'm really looking forward to the panel later this afternoon for some solutions for that, because I think it's a huge gap.
Well, I think that's a fantastic point, is the person who will write the check for that. It's much easier to get that check for the new product when it goes out than it is for the sustainability down the road. That's not very sexy, and nobody really likes writing that check, but it's the most important piece.
Yeah, follow up that sustainability question. So what I'm thinking is, I heard many African countries have a lot of second-use devices, and really we are delivering new technologies. We are trying to get all the data together, put things on the dashboard, and I'm wondering how do you integrate all these things together? I guess there is no standard APIs and all that. So how did you deal with this? Different generations of devices together and put the data together into one system. So I think we are trying to put different functionalities into one device, right? We are trying to put the heartbeat, monitor different things in one little device. What I'm thinking is, if we have different generations data, and then is it possible to put in one standardized dashboard? So here we have all of them.
I think it's beyond my remit to speak about that, but what I could feel is, if I use the CERN analogy, we have 10,000 different detector systems, all with unique manufacturers, but we standardize the data format and mark it up in such a way that if somebody wants to write a high-level application layer, that data can integrate into that system. In our case, we just monitored the temperature, the humidity, those things, and we developed a specific API for our system. But also the hospitals don't actually have very well-developed data management systems. So an open interconnect. I don't know if anyone else has tried.
No, I have sort of a different take, which was, I mean, I think going back to Dr. Rebecca's point about listening to the customer, I think it all comes down to, we get like, oh, why don't you add pulse oximetry on this bracelet? Why don't you connect it to a dashboard? Maybe when the parents come back, you can download the data and see tell the doctor how many times the baby had hypothermia. So all of that is like, I would love to do that as an engineer. I'd love to kind of be playing around, but at the end of the day, the doctor was like, we don't want to see this data when it comes back. We got like 100 things to see already. The nurses are like, so you want me to look at this dashboard and you want me to look at the baby. So I think it depends, the dashboard or the integration, if it's solving a key gap, then it makes sense. But to integrate for integration, it may just be.
Ratul, can I just bounce on that point? We did actually ask, because being scientists, we always wanted to do everything. And we went for red light, yellow light, green light. Green light was fine, don't have to do anything. Yellow light meant something was not quite correct, but we were handling it. And red light actually meant there is a problem, follow some procedure. And we tagged the phrase, we turned an emergency into an urgency. We remove the panic that happens. So when the lights go out because the power drops out, and they could see a green light or a yellow light still going, that was a relief to the health workers. And that came from asking, what do you want? And they actually didn't want the app. They wanted just a simple red, yellow, green.
As simple as possible.
Thank you for your question.
Thank you so much for this wonderful panel. Congratulations on your successes. I had a question about stakeholders besides end users, and maybe you could pick like some first. What was my first customer that bought the device, or my first interaction with a regulator or a KOL, maybe to share with some other newer innovators?
You mean?
Oh, you're the first to sell something.
Oh, like what? You're saying like how'd it go when we first hit the market? Like how did we get punched in the face, I think? Yeah. No, I mean, I remember we got this opportunity to sponsor a conference for a neonatology, like you come to my conference, there's gonna be a lot of doctors. So we're like, okay, this is the conference. So we had a grant, I got 3 of my people, we're all flying to Mumbai. We have to build 200 watches. Okay, this was our first conference. We're gonna have to build 200 watches because we might sell out. The doctor said there's gonna be 600 doctors there. Each of them buys, a 1 watch. We're gonna be out. So everyone's working midnight. We go there. And again, they were like, what? We got our first sale. So definitely our first sale was, I think if you look at the adoption curve, there's these technologists, who are like early adopters, this is cool. Definitely we found 3 of those doctors, and they later on, we're still in touch with them. They gave us feedback. There were still issues with the product, this kind of stuff. So I think that was very encouraging because we saw that, but the vast majority of clinicians are quite risk averse, and they were like, okay, so you've got this bracelet that's going to tell when the baby's cold. So parents are going to overheat their baby now. I'm going to get all these babies who are like overheated and overwrapped. Like reasonable concern. Maybe we needed some evidence around that. No, this is going to cause a rash. It's going to so there. Gosh, I'm trying to think of some of the other silly. Maybe now in retrospect they're silly, but it was rough. We sold I think 3 units out of 200. But it was a good learning. I think the technology part was easy, relatively. The marketing and the stakeholders is the hard part.
But maybe if I could interrupt you, how did you maybe even identify like who your customer was? Because it sounds like you were targeting doctors. Is that your ultimate customer, or is it the parent?
Yeah. So. I spent that time in the field, and I saw this as a public health need, and I wanted to build this for the government But I couldn't go with 200 units in a prototype, and someone had heard of that. So we wanted to test the market early. So we got to market, and the only way you could test it early was to sell to neonatologists in private hospitals. And we went to charitable hospitals and so on, but actually our first customers were the premium hospitals, UK-trained doctors who were aware of hypothermia and that they were discharging low-weight babies. So, I'm sorry, was that your question?
Yeah, it was just about identifying who the customer actually is.
Yeah, so that field research, I was pitching concepts to them, seeing who they resonated with, and then that helped me identify who I thought would buy and who wouldn't, and also the product features.
We worked out that there were two customers in our case. So there was a government, which ran half of the health system, and the churches that ran the other half. And we found that the discussions with government were extended factorial, but we could actually get to decision makers in the church system. And so the first successful service that we actually contracted and worked out how to pay for it was with the Catholic Church, then actually taking responsibility also for some of the government health centres. And I'm no longer, I've stepped down from that day-to-day running, but I would be surprised if government health centres were able to pay. They just didn't have discretionary income. And that was a great thing. SLAB taught you. I was a physicist. I didn't know about market demand and total addressable market and all these things. And I quickly worked out that they were great economics terms that don't map well into LMICs because there are no people to actually write a check too easily. That's the poison microphone.
I know. I was like,
Oh, yeah, sorry. Mm-hmm.
Well, thank you so much for sharing your stories. It's really great and entertaining also to hear them. I just wanted to pick up where, Rebecca, you were speaking earlier, and also Torre was talking a little bit about donorship to ownership, right? And that sort of scale pathway. So it sounds like, and Ratul, you also mentioned as you were speaking, you can't just have a business with one product, right? So, I think you each represent different types of organizations and business structures, or your companies or your organizations do. And I'm just curious, where are you in that sort of donorship to ownership pathway? How much of your company or organization is now being funded with sales or with non-donor funding? Or are you still feeling like you're quite reliant on donor funding to advance your product and move forward? Do you foresee that there will be a time when you will not need donor funding? Or do you think that, there's always going to be a need at some level for some amount of donor funding to support the products that you're talking about here?
I think that's such an important question. Let me answer just a piece of it, and from the technology perspective. So one of the things that we've tried to do in Nest is look at, if you want to provide a bundle of technologies for comprehensive newborn care, what's available commercially that meets target product profiles for low resource settings. And so Nest, led by Carapella Mountain, worked with UNICEF to develop TPPs. And there are things on the market that meet those TPPs, and we've tried to help identify and make that more visible so that people who are making purchasing decisions can make informed purchasing decisions about what things offer good value for money. So I think certainly there is availability in the commercial market, and some of the manufacturers are intentionally addressing low resource settings. Others mostly are more interested in high income settings, but if they can get some additional sales in a low resource setting, that's great. So I think that's available, and innovation is continuing to happen. But there's still an enormous gap in terms of being able to purchase enough tools that are needed to deliver quality care, and really making the case that investing in that is important and needs to happen. I mean, we all know neonatal conditions are the leading cause of death in Africa, the leading cause of death in low-income countries. We're not going to change it without level 2 care. We have to figure out how to address this funding gap.
I guess I'll say something just really quick, which, I mean, ours is probably like the least advanced technology up here, honestly. Like everybody else's is pretty amazing. So the clinics where we work are already a healthcare clinic that has no light. And typically when you talk to the staff, I mean, honestly, a lot of the staff don't even get paid for like 2 months, and then they'll maybe get a check now and then or something. And so the idea of somehow that funding coming from that community or from that healthcare center, I mean, we've looked at it everywhere we can, and we cannot figure out a way. We've looked, people say like, why don't you sell to the camping community in the US or whatever. Well, our product honestly is not the one you probably would want to go camping with, because it's not designed for that. Goal Zero does a fantastic job of that. But where we really excel is a healthcare, health clinic 2 or health clinic 3 out in the middle of nowhere. And so I think it's really, really hard when you're trying to serve a health center that starts out with no light. I mean, it kind of starts you off at a place that's hard to come out of.
Yeah, it's a challenging question. I mean, I think we had our grants until 2021. And the grants essentially, or the Saving Lives at Birth essentially allowed us to take big risks and try to get big sales. And we almost, almost isn't there, but we got in, like $2 million budgeted in the Indian government, but we couldn't get it out. And, it was like heartbreaking and things like that happened. But definitely there's, so after all that, I had to take a hard look if like I want to keep trying to sell to the Indian government or not. And we also had a big team and everything, 50 people. And it forced me to cut down, I after that, and forced me, I took some time and decided that for right now, we need to find a cash cow. We need to find something that's just generating money so that I don't need to wait like for the next. And then when Saving Lives at Birth closed, it was also a little like, oh no. Not that we were like counting on them, but it gave this like, okay, maybe there's not so many applications out there. So so we cut down costs. We also then, we cut down costs. We didn't raise grants. We also didn't raise grants for complicated products. We launched simpler products like the Kanga Sling, the belly button. Apnea was still a more complex product, but there's some simplicities into it. And we also started launching our belly button and our Kanga Sling in the US market. And so this gave us, we're sustainable, but can't take the big risks like launching class 2 products or going back to all the governments and trying to get those sales again. But yeah.
It's a great question, Trish, about donorship to ownership. So our analysis showed that the donors were always willing to give equipment, but donors were always disappointed 3 years later when they visited and all the equipment was busted. And so we flipped, and I suppose we shifted the paradigm to oxygen as a service, as 302, where we felt that the community could pay for the service component because we were hiring locals, and that was within the economic framework of the local community. And so we got down to small, like $50 a month charges for the health centres, where they knew that was actually going directly to employing the staff that were maintaining the systems, and then lean on a donor to get the 5,000 or 10,000 CapEx, with the idea that you may be able to prove with the data, the question that came before, that we could increase the longevity of that donation and therefore improve that, but never shifting the CapEx burden onto the community, because there's not sufficient economic resource there for the oxygen.
Thank you. All right, I think we have time for one more question from the audience.
Thank you for a great panel. I'm Rose. I'm a postdoc from MIT, and I'm in a problem-finding journey. So when Dr. Rasool talked about 4 Eyes and innovation, ideas came first, but I was like, well, where's the problem finding? So I'm wondering, there's so many problems out there. You can do 2 years of field work to find a problem. and you have a certain set of technical capabilities as a scientist. How do you find that one problem that you're going to tackle with the capabilities you have?
And
Can
then
I
if
just
if
grab a very quick response? A fantastic question. In other words, don't have a solution and then look for the problem for it.
Yeah.
And Rebecca said, talk to the people. And it was Trevor Duke. We as physicists went along to a global health challenge where doctors told us they're working in Papua New Guinea and they had no electricity for oxygen. So listen.
No, I think just going off of that question, so about identifying the problem. So I guess, yeah, as entrepreneurs and like leaders in this, you've been working in this field now for over 12 years. Yeah, what problems do you continue to see persist? Or in other words, maybe what opportunities remain for maybe some entrepreneurs that are out there?
Safe reprocessing of consumables, I think, is a big unsolved challenge. And I think if that could be solved, it would have such an impact.
I think getting your foot in the door is just a lot of it, because like our product was started because Dr. Laura Satchel was doing some masters in public health work in Nigeria, looking at high maternal mortality there. And it was just an aside that the electricity would go off in the middle of surgeries and such, and people didn't even comment about it. The lights would go off and they would just react. And she's like, what about the light? Like, don't you need some light? And so this entire product sprang out of not where it started. And so I think a lot of the problems will expose themselves as you work in, whatever you start.
Yeah, I mean, I think two things. One, spend some time with customers who you'd like to spend probably the rest of your 10 years or whatever you're doing as a startup idea working with, So I talked to a lot of doctors and I kept watching them, and I kept writing down. I have a list of maybe like 200 or 500 different like things I saw, like, they couldn't take off this sticker off the baby, or he dropped his bottle when he was carrying this. And then, so that helped me identify, I guess, real problems. The second piece of advice I got once was like, just start with the wrong problem and build something. So I started with, I was making a bedside C-reactive protein test. So you could, instead of having to run down to the lab, you could see. And I made a PowerPoint slide and I was like, hey, look, I'm building this. And doctors were like, what? We don't want to do that. Yeah. So I kind of built the wrong thing and got feedback quickly that this was not something that I should work on, and eventually pivoted into something.
Okay, great. Thank you.
Thank you. All right, and then just to wrap up the panel, I'll just give you guys each a second to give maybe one kind of key, one sentence, maybe key takeaway for the audience.
I think if you're looking for good problems, listen to nurses, ask them what they wish they had, and you will get a lot of really fantastic ideas, and make them a key part of your journey all the way through, because they're the difference between success and not.
I guess I'd just say keep at it. You're going to get a lot of advice you don't want early on. And you have to keep in your mind that you know what you're doing and keep at it.
Yeah, I think you took the words out of my mouth. It's not easy, but these are like big problems and they need solving. And no one said it was going to be easy. And we showed you, I think you guys discussed the problem. There's a lot of problems and challenges, and you just have to be resilient. I think, again, the problem needs someone to work on it.
I think the key thing is to work out what drives you, what actually brings you to work or thing every morning. And so 2 words of advice I got from people like Karen, Wendy, and Noah. I learnt the word pivot, which I never knew what it meant, so I had to go and look it up. And the other word I learnt was exit strategy. And I never believed I needed an exit strategy, but I executed it just 11 months ago, which was to actually step down from day-to-day running of 302 and realized that my heart was really still in that innovation side of it, and to be proud of the success of what you've built and allow that to grow with somebody else and focus on what you like doing. Yeah.
Wow. Thank you to each of you so much for sharing, I think, your progress and your journeys, your challenges, your pivots, and your successes over the past, my goodness, now 12-something years, 14 years. So thank you to each one of you and for all that you're really doing in terms of maternal and newborn health.